Ready, Madam Chair, we'll go ahead and begin. I know some people are presenting bills likely in other committees, so.
So you want me to start? Okay. Are we recording?
We are live.
Thank you. Welcome to the Senate and House Human Services Subcommittee hearings. We're going to start today. We're going to hear the budget of DHS Social Services, and we'll have Tanya Zimmerman, the analyst, provide anything. Did you have anything, Madam Chair, before we start? Okay. Tanya, you want to start us out?
Yes. So today I have the administration of the Department of Human Services. The budget increases by $9.8 million. That increase is almost entirely in the foster care maintenance payments program. The rest of the budget, if you exclude that, decreases by under $400,000. Exhibit 1 presents information on child maltreatment reports. This is monthly data back to fiscal 2016. As you can see in this data, the number of reports tends to fluctuate during the year, and this is largely related to the kind of school schedule. So you have decreases during the summer months when school is out of session. At the onset of the pandemic, there was a significant decrease in the number of child maltreatment reports, falling well below even typical summer levels, because it wasn't just schools that were closed, the daycares were also closed, many of them, and doctor's visits as well. And it has remained kind of at that lower level since that time. It's approached closer to the summer levels, but it's still well below typical levels. Adult abuse reports have also fallen compared to the prior year level. This is closer to historical levels. Fiscal 2019 was a higher than typical number of reports, but the department indicates that this is also a national trend due to the closure of adult day programs. There's one deficiency appropriation for the Social Services Administration. As you may recall from last year, there was funding for a 2% provider rate increase for providers whose rates by the Interagency Rates Committee. That was consistent with the BRFA of 2020, which limited rate increases for those providers to 2%. However, as part of the budget balancing actions, the Board of Public Works approved a reduction of those funds so that in general, provider rates stayed at the same level compared to fiscal 2020, unless adjustments were made based on programs. However, the deficiency provides funding for a temporary 2% rate increase from January through June. That would apply to all providers except for those who receive those program adjustments because of the cap in the BRFA. It's the analysis of DLS that the department has sufficient funding within their budget to cover their temporary rate increase. And so we've recommended the general fund deficiency appropriation be deleted while still providing the temporary rate increase. Exhibit 5 on pages 10 and 11 here provide information on the changes in the agency's budget. The major changes that really are in the foster care maintenance payments program, and they're driven by, the increases are driven by a couple factors. There's a $12.6 million increase that's related to higher estimated placement costs for purchased institutions, which are the group home placements. And this is just to better align with the recent payment levels. There's also funding to support a rate increase of up to 4% for the providers with rates set by IRC. That's 4% compared to the rate that was in effect before this temporary rate increase. The funding is $6 million, but it's offset by the funding that's in the budget for the temporary rate increase. The other notable change in the foster care maintenance payments is a decrease of just over $3 million. It's listed here as flexible spending. This is basically spending that's not on the placement itself. but that includes educational and daycare expenditures, and they decreased it to align with the fiscal 2020 expenditures. However, those were not typical expenditure levels because of the pandemic. So it's possible that that level of expenditure will actually be higher than what's included in the budget. One more note about the budget is that last year in the budget, there was language that restricted funds until or unless the department and the Department of Budget and Management included in their submission detail that separated out the placement, the hospital payments for hospitalizations that are not covered by Medicaid due to not being medically necessary. The detail was not specifically available in the budget submission. However, the Department of Budget and Management subsequently told DLS that the subprogram that was requested had been created and provided the spending detail for the recent years. And so DLS is recommending the release of those funds and will process a letter to that effect if you do not raise any objections at the hearing. In terms of the caseload trends, the caseload has generally been declining over recent years. And however, in fiscal 2020, the caseload decrease accelerated to about 4% compared to decreases of less than 2% in the years leading up to this. And then through December, the decrease has accelerated even further and is over 12%. These trends occur for a number of reasons, including reduced entries into care, but also due to factors such as like lower movement between placements and some distortion of the placements in fiscal 2020 due to some provider rate increases. Overall, out-of-home placements are up slightly compared to this time last year, but that includes placements that aren't paid for through this program. Subsidized adoptions and guardianships have also had a change in the trend from recent experience. Subsidized guardianships have increased for more than a decade. However, they decreased in fiscal 2020 slightly and have decreased further so far in fiscal 2021. Subsidized adoptions have decreased in all recent years, but the decrease was much higher than normal. It was about an 8.5% decrease in fiscal 2020 and continue to decrease in fiscal 2021. These have been impacted by closures and the reduced operations of the courts, which are necessary when children exit care through these methods. So overall, DLS is projecting a much lower caseload in fiscal 2021 than was assumed in the budget. The budget was developed prior to COVID, so the impacts just couldn't have been known. So we're projecting a much lower caseload. For fiscal 2022, DLS's overall forecast is very similar in terms of the total numbers. There are differences among placement types, which impact the overall cost of the program. For the placement costs, DLS, however, is expecting higher costs in fiscal 2021. Again, part of this is COVID related as they provided additional supports to providers, but it's primarily driven by the purchased institution or those group home placement costs. The budget, as it was built, assumed a lower level of placement costs than were occurring at the time. There were some unusually high rate increases in fiscal 2020, and the budget didn't reflect the full annualization of those increases. So that's the primary driver of the fiscal 2021 costs being higher than projected. In fiscal 2022, a similar action occurs. The purchased institution placements are closer to recent levels, but are still lower than what DLS is projecting. Although on the whole, DLS and the budget have kind of a similar overall placement cost estimate. And due to the combination of the lower caseload, even with some of those higher placement costs, DLS forecasts that the department has a surplus in the program in fiscal 2021, which is what leads to that recommendation about the deficiency appropriation. In fiscal 2022, however, DLS forecasts a shortfall of about $4 million in general funds, a little bit higher overall. So that's in part due to the purchased institution placement costs, but it's also driven by the expectation that the educational and daycare expenditures will return to more typical levels. In terms of the personnel, the item to note here is that there are 19 positions that are abolished in the agency. These are all long-term vacancies, and so they do not expect an impact as a result of that. So the first issue in the analysis is related to the hospital stays. This has been an ongoing concern over the last several years, and you've requested information on the number of youth in hospitals over the last several years. The report, as it was submitted this year, didn't include any new months of data compared to the prior report. This happened because the department changed the source of data. It appears because the medical stay data was different, the medical hospital data was different, and the numbers themselves were different. But they reported the data this year from the public behavioral health system, which had difficulties in the transition to the new administrative services organization contract. And as a result, they didn't have data after September 2019. So there was no new data presented in the report. However, the governor's Office of Crime Prevention, Youth and Victim Services annual out-of-home placement report did include some data on hospitalizations for fiscal 2020. They reported there were 791. One of the things to note about this is it noted that a small number of youth, it was like 25 in total, had 5 or more hospitalizations, and they represented a large share of the total hospitalizations. The emergency room visit for psychiatric and evaluation or crisis was also impacted by the use of the data from the public behavioral health system, but this was new data that was requested for the first time in last year's report. So they provided 15 months of data, and in 10 of those, there were 40 or more ER visits for psychiatric evaluation or crisis in the month. The report also requested information on placements after discharge. This combines data on placements from after discharge for fiscal 2019 and 2020. The notable things here, there were differences for discharges from medical settings and inpatient psychiatric settings, kind of in 2 primary areas. Medical hospital discharges were more commonly to family settings, while inpatient psychiatric discharges were more commonly in group homes or residential treatment centers. This would not be unexpected as they are likely to require higher levels of care when discharged. The other notable thing is that among both placement discharges, about 10.9% were to other hospitalizations, which kind of emphasizes the concern about the youth that are having kind of repeat hospitalizations and leads to concerns about kind of discharge planning and the placements after discharge to ensure that they're being placed in places to kind of alleviate these kind of crises. They also presented data on calendar 2020 stays beyond medical necessity. This is only through September, kind of mid-September. They reported 20 total stays beyond medical necessity during that time, 8 of which were for 50 or more days. Most of those kind of long overstays were from kind of inpatient psychiatric hospitalizations. In the out-of-home placement report, they described findings of a review that was intended to help address discharge challenges. And so they looked at some of the service gaps, and they noted in particular the need for specialized services for youth with combinations of autism, spectrum disorder with aggression or sexualized behavior, similarly with developmental disabilities, and other youth with histories of aggressive behavior and certain other types of behavior. They noted that the residential treatment centers do not necessarily offer the programming that these youth need, and the youth are sometimes rejected due to minimum IQ requirements or the highly aggressive behaviors. Apologize. You also last year had requested data on the number of additional licensed placement beds that would be needed to kind of address the overstay issue, so that children would have places to go when it was no longer medically necessary. The report, as it was submitted, indicated that they couldn't provide a comprehensive listing of the number of additional licensed placement beds that were needed. However, the budget includes $5 million of funding in the Behavioral Health Administration to begin to address this issue. It's intended to be used for a potential grant program, and they've released a request for expressions of interest for residential treatment center providers who would be able to take on these higher acuity patients. They would receive additional funding beyond the typical Medicaid rates, and they would have to accept the patients. Although they didn't, in the report that was submitted to you in November, provide a number of beds that would be needed, they did indicate in that request that there would be 18 beds initially and maybe up to 25 annually. And we asked the department to comment kind of how they're working with the Behavioral Health Administration on this initiative and how they determine the number of beds that would be needed, given that the November report did not include that data. We've also requested or recommended budget bill language to provide data on the hospital stays and the ER visits, since no new data was provided in the last update. The second issue addresses some federal fund opportunities that the department is missing. Under the existing rate setting process, providers who have rates set by the interagency rate committee receive one rate for all allowable costs. And they're individually set based on program specific costs. Because of the one rate for all costs, including direct care and clinical costs, they have not been able to claim Medicaid funding for foster care placement since fiscal 2015. This exhibit provides information on the amount of Medicaid funding they were receiving prior to that inability to claim. And then from fiscal 2012 through 2015, it averaged about $16.4 million. And they were spending about $7 million of TANF in the program at that time. After they couldn't claim Medicaid, the use of TANF increased in the program to a minimum of 11.4 million, and in some years it's been higher. In the fiscal 2022 budget, they are using $31 million of Medicaid, but of TANF. So they haven't been able to claim Medicaid, and they have been using more TANF, which helps address some of the issue. But until they address the rate setting issue, they won't be able to claim Medicaid. And this was cited in a recent fiscal compliance audit. They did submit a report this year to you explaining a plan for a new rate setting process that should allow them to begin to claim Medicaid rates, because it would provide two rates, one for direct care costs and one for clinical care costs. Under the proposal they provided, they would have begun rolling out the new rate setting process in fiscal 2023. And then kind of concluding the rolling out in fiscal 2024. However, subsequent to the submission of that report, the Department of Human Services indicated to DLS that the vendor they were going to use to help them develop and test those rates is unable to perform that work. And so that is likely to delay the implementation of the new rates. And we've asked the department to comment on the new timeline and when they anticipate beginning to claim Medicaid rates again, Medicaid for foster care placements again. The second issue relates to a change in the Family First Prevention Services Act, which limits the federal funding for group home placements to 2 weeks unless it's a qualified residential treatment program. The department indicates that they've submitted a plan to the Bureau to receive approval, which until that is approved, they cannot claim the federal funds for these placements. However, they have not yet received approval. They are working towards the process, but they do not have the approval yet. And the department to comment on the impact, potential impact of the delay in the process and the timing to begin placement on these issues for these placements. The third issue addresses the kind of second key change in the Family First Prevention Services Act, which is the implementation of prevention services. The department was already providing prevention services under the waiver, and they were able to kind of quickly transition into prevention services under the Family First. They received approval for their prevention services plan in last year. And Exhibit 15 provides information on the services that are being provided by jurisdiction and the number of families that have been served in each of those programs. They have continued to serve people during the pandemic. However, despite having the approved prevention services plan, they do not have the federal approval they need to claim the federal funds. So as you can see in the 4 years prior, when they were operating under the waiver, they were spending about 50% federal funds, 50% state funds for the prevention services. In fiscal 2020, the spending was all general funds because of this inability to claim the federal funds. The spending was also lower. That's likely impacted by the pandemic as well as the transition between the waiver and Family First. So then in fiscal 2021 and 2022, the budget relies almost exclusively on federal funds for these services, even though they do not yet have the ability to claim federal funds for that purpose. And so we've asked them to comment on when they anticipate receiving that approval and request committee narrative, recommend committee narrative requesting they provide an update on the prevention services and the implementation of the QRTPs. The fourth issue, I'm not going to spend a lot of time on, but I just wanted to bring it to your attention. This discusses some of the issues surrounding youth that would have otherwise aged out of care and the supports that the department is providing to them as a result of the pandemic and they allowing them to stay in care. The state had a moratorium that allowed youth to stay in care that would have otherwise aged out of care. Recent federal legislation kind of has extended that moratorium. But it also requires some kind of public awareness and notification about that opportunity and the ability of youth who did leave during the pandemic to come back into care. And we've asked the department kind of what they're doing to comply with that. The legislation also provided a number of other changes to federal funds that are used to support these youth, and we've asked the department to comment on what they're doing to implement those changes. The final issue is the annual issue related to kind of where they are in terms of their caseload ratios. As a result of the lower number of reports and resulting lower number of investigations, it has improved the department's position in the child welfare caseload ratios compared to where they were last year. Fewer jurisdictions are kind of missing those caseloads. Overall, the state was meeting the caseload ratio last year, and they are again this year, but there are fewer jurisdictions that are missing those caseload standards. But we have asked the department what steps they're taking to kind of fill vacancies so that they're in position to meet the standards when the numbers are kind of returned to more typical levels. And finally, we have the recommended actions. A number of these I've already talked about, so I'm just going to highlight the couple that I haven't already addressed. This recommendation number 3 is annual language restricting the funding for the foster care maintenance payments to that purpose. The recommendation 5, and it continues on to the next page, is a recommendation for committee narrative asking for information on some efforts of the department under their own initiative and through legislation about savings for foster youth and the amount conserved. Recommendation 6 is also annual language that restricts the funding for child welfare services to that purpose. The other recommendations I've already mentioned, and with that, I'll conclude my presentation.
Are there any questions? Scanning through the little slides. Senator, do you see any? I don't see any.
Yep. Senator Eckert has a question.
Thank you. Thank you very much, Madam Chairs, co-chairs. I did have a question, Tanya, if you don't mind going back to the very beginning. I wanted to make sure I heard correctly about the rates, the provider rates, correct?
Yes.
The-
Yes.
Now, the department did get an increase, correct? Was that in January of this year, or was that for last year?
So for fiscal 2021, they are providing a temporary 2% provider rate increase beginning in January. They did initially have funding for a 2% provider rate increase for the whole year, but the funding was reduced by the Board of Public Works. So they are providing the 2% beginning in January. For fiscal 2022, they have funding for a up to 4% provider rate increase.
Okay, it is up to 4. It wasn't put back to 2. I'm just trying to figure out, we were working to get them 4%, correct? And then it was reduced to 2 by the Board of Public Works. Is that correct?
No, so these providers only had funding to support a 2% provider rate increase in fiscal 2021. And it was reduced so that their rates were the level funded. And then this provides them a 2% that's temporary. The 4% goes back to the rates that were in effect before the temporary 2%. So it's really over 4% what they were getting kind of at the beginning of the year. But it is separate from the mandated 4% rate increase, which was provided to other provider types.
Okay, so I guess I'm trying to get straight. With all the reductions and additions, is it equaling out to 2%? Is it closer to 4%? Or what is it for this coming year?
Next year's rate increase will typically be up to it's up to 4%, but it would really probably average out to a 2%. But ultimately, the rates are set by the interagency rates committee. So this just provides funding that would allow them to go up to 4%.
Okay, you've answered my question right there, because I was trying to figure out if the rates in the beginning of your presentation were related to what we'd been working on for a long time, getting that committee and figuring out what the reality is. Okay, thank you. Did I get it straight now?
Yeah, it's a little complicated because of this temporary rate increase, I think.
Yeah, that's what I didn't want. Yeah, thank you.
Senator Young, did you have a question?
No, I'm listening and learning. This is all new to me.
Okay, very good. Yeah, it is. Okay. Madam Chair? Anything else?
Okay, I think that ends the questions for Mrs. Zimmerman. We'll now bring up the department. We've got Secretary Padilla, Ms. Kip Brett, Deputy Secretary James, Michelle Farr, and Stafford. I know the Delegate Resnick, Chambuga. Did I say it right? Champanga. Thank you. Apologies. So do you have a particular order, Secretary, or do you just want to start?
No, I just want to start. Thank you. Thank you, Chairman Griffith and Chairman Resnick, for the opportunity to discuss the FY 2022 budget allowance for the Social Service Administration. My team with me today, as the co-chair said, Stafford Chipango, Ms. Anna Red, and Greg James. I want to take the time to thank Tanya Zimmerman for her comprehensive analysis of DHS's Social Service Administration budget. As always, she's a pleasure to work with, and we appreciate all her support. I also want to take the opportunity to thank the local directors and the staff at our 24 local departments of social services for all their hard work through the past year, and especially during the COVID pandemic. Without them, there is no DHS. I have a testimony, which I won't repeat here. However, before I address the issues and recommendations from the analysis, I would like to take a moment to highlight some of our activities and accomplishments for the committee. The COVID-19 pandemic created many challenges for the Social Services Administration. Despite the pandemic, our work had to continue because the services we provide to vulnerable children and adults are essential. DHS responded to the pandemic by adjusting its policies and practices and changing how we conducted business. We allow youth to remain in care past 21 instead of aging out. We conducted virtual visits and provided technology to support the virtual visits. We equipped caseworkers with appropriate PPE and infrared thermometers for in-person visits. We provided supplemental payments to providers, and we modified license requirements for providers. Speaking more broadly to the work of SSA last year, over the last year, DHS continued to support children and youth who were victims of abuse or neglect. As of December 31, 2020, there were 4,630 children in out-of-home placement. Of these, 3,303 children and youth were in family foster care settings. 438 youth were placed in group homes or similar settings, and 189 children and youth were in independent living residential treatment or other settings. In FY 2020, DHS group home placement are less than half of what they have been in 2007. In 2007, nearly 20% of youth were in group homes. In 2020, only 9.5% of youth were placed in group homes. In FY 2020, 1,100 children achieved permanency, exiting foster care to safely return home, moved to guardianship, or to be adopted. That means that 77% of children who exited foster care in FY 20 exited to permanency. This is an 11% improvement over the FY 2008 rate of 66%. Since FY 2012, more than 18,000 children have exited foster care to permanency. With that as a backdrop, I would like to speak to some of the most significant initiatives currently underway. We continue to implement the Family First Prevention Act, or Family First as we sometimes refer to it. We have submitted to the federal government for approval the Prevention Plan and Cost Allocation Plan. We anticipate approval from our federal partners by April. Our interagency effort to restructure how the state pays for residential services has also continued. Together with our sister agencies, we have defined the structure of the new rate setting methodology. The rate structure will unbundle the direct care and clinical services. Rates will be set based on the class of service being provided instead of individualized rates for each program. A new vendor to perform the actuarial work for rate setting is being procured. The target is for the rates to be in place for residential childcare providers by July 2024 and in place for all providers by 2025. Medicaid claiming should begin in FY 2026. On the issue of children who remain in hospitals past the point of medical necessity, we continue to be very focused on the issue. Working together, the Children's Cabinet has developed an interagency plan to address this issue. The governor's allowance for FY 2022 includes $5 million to the Department of Health to provide 18 additional psychiatric residential treatment center beds targeted at this population. I would like to share with the committee more about the important work that we do protecting and supporting vulnerable adults. In FY 2020, the Office of Adult Services provided services to thousands of vulnerable adults. We performed nearly 6,500 adult protective services investigations, served more than 1,100 vulnerable adults under adult public guardianship, provided in-home aid services for more than 1,700 individuals, and helped more than 400 clients remain in their homes and avoid more costly institutional placement through Project Home. That concludes my opening remarks. Now, with your permission, I will move directly to the issues and recommended actions in the analysis.
Thank you.
On the analyst recommended actions are listed on page 3. The department concurs with 6 of the analyst 8 recommended actions. On recommended action number 1, the department concurs with the recommended report, but respectfully disagrees with recommended fund restrictions. We respectfully disagree with recommended action number 8 to delete the general fund deficiency appropriation for a provider rate increase due to surplus funding in the program. And I will elaborate on this more when I discuss issue number 1. On that note, I will now move on to discuss the issues. In response to issue 1 on page 8, regarding the recommendation to delete the general fund deficiency appropriation while still providing the temporary rate increase, the department respectfully disagrees with the analyst's recommendation. We believe it would be prudent to leave the funds in budget since the general fund appropriation in this program is restricted and any general funds not spent must be reverted at the closeout. We cannot use those general funds in any other program. In response to issue 2 on page 10, Regarding releasing the 100,000 in general funds, the department concurs with the analyst's recommendation. In response to issue 3 on pages 23 and 24, regarding our work with Behavioral Health Administration and other sister agencies to develop additional resources, the department is working with and providing technical assistance to BHA as needed as BHA seeks to develop additional residential treatment center resources. In particular, we provided information to BHA regarding the complex needs of the youth that the new placements will need to meet. BHA estimated 18 beds would be necessary, with the understanding that the numbers may fluctuate. We continue to coordinate with BHAs on this effort. In response to issue 4 on page 24, regarding budget bill language restricting funds until DHA submits recent data on hospital stays, ER visits, and placements after discharge, the department concurs with the analyst's recommendation to provide a requested report. The department respectfully disagrees with the analyst's request to restrict funding until the submission of a report, however. In response to issue 5 on page 26, regarding the timeline for the new rate setting process, the department concurs with the analyst's recommendation to adopt the committee narrative requesting information on the implementation of the new provided rate structure. The interagency work group has established the new rate setting structure, as I discussed in my testimony. The next critical step is performing the actuarial studies and work to support the actual setting of the rates. After a recent setback, we're working to procure a vendor to provide that expert technical assistance. Because of this setback, we now estimate that the new rates for residential childcare providers will be implemented by July 2024, and the rates for all the providers will be implemented by July 2025. Based on this, we anticipate Medicaid claiming under the new rates to begin in FY 2026, subject to federal approval of Medicaid state plan amendment. In response to issue 6 on page 27, regarding the ongoing work to implement the new qualified residential treatment provider process, the department concurs with the analyst's recommendation to submit a report outlining the status of the implementation of Family First Prevention Services to include all requested information by October 15, 2021. All of the required plans related to QRTP provisions have been submitted to the Children's Bureau. We anticipate receiving a response by April 2021. While the plan is under review with the Children's Bureau, the department continues to work on ensuring the infrastructure activities related to QRTP are being addressed. In response to issue 7 on page 31, regarding the anticipated approval of the cost allocation plan, the department concurs with the analyst's recommendation to submit a report outlining the status of implementation of Family First to include all requested information by October 15, 2021. The final version of the cost allocation plan was submitted on January, and the Children's Bureau has until April 2021 to provide a response. I want to take a minute though to discuss some of the actions we have taken as we wait for the CAP approval. We have established an implementation team with cross-agency membership. We have developed a training plan for child welfare staff to support the implementation of prevention services. We have developed the continuous quality improvement processes required by Family First and developed a draft QRTP application process to support the identification of QRTPs. And we continue to provide technical assistance to our 24 local departments regarding the identification of evidence-based practices, prevention services, that may be implemented or expanded within their local community. In response to issue 8 on page 32, regarding the efforts to comply with the public awareness campaign requirements and to re-engage with those youth that left here during the pandemic, DHS welcomes the federal measures to expand services to include former foster youth who have left care during federal fiscal year 2020 or later. In coordination with our federal partners, the department is working to build on and expand our public awareness campaign to include outreach and information for youth who have left care. This outreach is occurring through multiple channels, including various forms of social media, because that's where the youth are today, right? We're working with the Fostering Change Network to reach foster alumni, and we're collaborating with other partners to get the message out whenever and wherever possible. In response to issue 9 on page 33, regarding the status of DHS efforts to expand its current support for older youth and incorporate new temporary federal changes in this area, the Children Bureau has not yet provided additional guidance for the implementation of these temporary measures. DHS is working with other state child welfare agencies to identify critical questions where additional guidance is needed from the federal partners. When youth do come back into care though, they receive the same services that DHS provide to any other youth in care. While awaiting this guidance, the department has continued to take steps to strengthen our services for older youth, including conducting a housing resources seminar in partnership with the National Center for Housing and Child Welfare and Fostering Youth to Independence, a HUD initiative to promote housing stability for youth transitioning from care. Partnering with the Maryland Department of Disabilities to provide housing opportunities for youth with disabilities. Building youth perspective through the Youth Advisory Board and Youth Ombuds to support youth transition to independence. And holding a strategic planning meetings with partners to develop a training curriculum by July 31st, 2021. In response to issue 10 on page 34, regarding the department's effort to fill vacant caseworkers and supervisor positions once activities to return to some typical levels, the department believes that its current efforts to attract and retain staff has been successful, based on the data which indicates that DHS is meeting the Child Welfare League of America caseload standards. DHS has been proactive in its efforts. During the COVID-19 pandemic, the department has continued to recruit and hire caseworkers and supervisor positions. As of February 1st, 2021, there were 53 more filled caseworkers positions than there were on February 1st, 2020. We believe we will continue to have the staff we need to meet the standards that are set by CWLA when activities return to a pre-pandemic level. This concludes my testimony and response, and I will be happy to answer any questions the committee may have. Thank you.
Okay, thank you, Madam Secretary. I see we've been joined by Chair Resnick. I don't know if he's ready to take over, or we'll go ahead and call on the Vice Chair Valentino Smith if you had a question.
Thank you, Madam Chair. I didn't see any others. I didn't mean to have to go first.
Help yourself.
So thank you, Madam Secretary. I think we all almost feel your exhaustion for what you've been doing and what you've been asked to do in these unprecedented and historic times for a very vulnerable population. So we still want to try to understand and ask a little bit more. Back on pages, I think it's 24 and 25, if you talked a little bit about it in your budget response. Obviously we have concerns about not being able to get the Medicaid money. And now that the TANF surplus and reserves are spent down, what it means to us, and when we sit here, is that we're spending what it might be almost $30 million in money that ultimately could be spent in other programs because we're unable to bill the federal government under Medicaid for the clinical charges. And that stopped in what looks like the chart that Ms. Zimmerman went over in 2015. And in your notes, you're telling us that it might be 2025 or we're able to bill. And I don't know, I think the chair's telling me it might have been 2026, was it? But let's do math out loud, but I think we're at 10 or 11 years. Is this, and I know you had a vendor difficulty you explained to us, but aren't other states doing this? Can you reach out and get some immediate and expeditious assistance so that we can capture the $1 million in federal money that we need to get some relief off what we're spending in the general fund? These are millions of dollars.
Very, very good question and remarks. And I can tell you that I share your frustration. Very unfortunate that when I thought that we were so close to be able to unbundle and start being able to bill Medicaid, there's a critical step that needs to be done, which is called the actuarial work, that defines exactly what services are billable to Medicaid and what services are not available that would need to be then funded by general funds. And that work must be done by them, by this actuarial work vendor. And we thought that we had the right agency vendor that was going to do that work. And it's very unfortunate because it's very late in the planning process where we lost that vendor. And unfortunately, and I say unfortunately because I share your same frustration, and I know the committee as well, we need to put an RFP. At procurement, I need to put out an RFP to get this actuarial work done. I would love to be able to reach out to other states, but unfortunately, this piece must be done, and it's a requirement that Medicaid will ask, and that it cannot be skipped.
But 4 years? I mean, we're in 2021 and you're saying not till 2025 or 2026 we'll be able to unbundle and bill the federal government?
The only shortcut that we would be able to do, and I know is not something that Maryland procurement law would allow us to do, is to do a sole source contract. And as you and I know, that's something that, and I'm very proud that we don't do that, is not feasible. So, and that's why it's taking so long, is that procurement process that unfortunately can take 1 or 2 years. And I have, if I may, I have Deputy Secretary James. I have been working very close with this process. And I don't know, Deputy Secretary, if you would like to add to anything that I said that I could have missed.
No, Secretary, I believe you covered virtually everything. I think what's important is, the first time you go through this rate setting process, Medicaid is going to want to see that the rates we set were tied back to real world economics. And that's where this actuarial study is so critical and such an essential part of the process. And it's not just performing that study, but also setting up the methodology to do it the first time through that we anticipate will require, and what the feedback we had received from both the prior vendor and others that we've spoken with seems to indicate that they will need about a year to perform that study. So once we get the procurement done they'll need about a year, and then the rates will start going into place for the first cohort of providers, and the following year, the remaining providers. Certainly, if there's any way that we can accelerate this process, we're going to push to do that.
Thank you. I can't express any more the frustration or not understanding since 2015, not being able to accomplish this. Madam Chair, Mr. Chair, if I may, just one more question. On page 7, we talk a little bit here about this wonderful new ability for the CJAMs to have data and for it to begin to be used to do risk assessment and identify families by risk level. Is this CJAMs part of the great MD Thinks, and how is all this communication and coordination, and where are we with MD Thinks and the ability for everybody to communicate in one silo, which was supposed to be the great end all of solving a lot of our problems in case management?
Thank you. Very good question. It is. The CJAMs is the new CHESI. If you would remember, CHESI, the child welfare system, CJAMs is the new CHESI, and it is indeed part of MD Think. And CJAMs is complete. It's totally roll out statewide. And the caseworkers are using is their new child welfare system. And what it allows and will continue to allow is to identify key data points that we need to collect, like this one, as you stated, so we can then have the reports that we've been wanting all along. And this is one of the samples. So CJAMs is completely roll out statewide, and I'm very pleased that we've been able to do that. And then the other ones, the other modules within the MD Think, which is the eligibility and enrollment piece. And we're going to be talking more about this next Monday, right? But the eligibility and enrollment piece is the next one. And that's the one that touches your TANF, your SNAP, your TDAP, long-term care, all the other modules. But in this context, Social Service Administration, CJAMs, is completely rolled out.
So we'll hear a little bit more next Monday. Thank you. And Mr. Chair and Madam Chair, I'm sorry, just in one more. Last year I raised this, and it's very sad to have to raise again this year, but in the child fatality rates, it says that we continue to remain high, and Prince George's County, Baltimore City continue to rank high. I know you've got some general language about the interventions that you've tried to take in those counties to reduce child fatality. What I almost fear is that the numbers will even be greater, or we don't have the children in the system that we need. But I would like you to at least send to us, not now because you've put general language in and what you've done, specificity of the programming that you've implemented to try to help reduce the fact that the child fatalities remain high. And so thank you. Thank you, Madam Chairman.
Thank you so much.
Okay, thank you. And I apologize to everyone for being late. I had another meeting that ran over and I wasn't able to join. We have a number of folks who want to ask questions, some of whom are not able to raise their little hands. So we're going to start, just to give you the order, we're going to do Delegate Henson, Delegate Young, Senator Eckert, and then Senator Young. Delegate Henson, please.
Thank you, Mr. Chair. I hope that everyone can hear me. Madam Secretary, thank you for persevering despite the weather. You're usually there with your supporters, but I see that you're there by yourself today. I wanted to ask about the budget analysis, specifically the maltreatment reporting and investigating that the department does. The report shows that the maltreatment cases have declined sharply. And then when I was looking at the staffing levels, it looks like the only changes there are deleting some long-term vacancies. So what that said to me is that you have a number of employees that aren't doing the historic workload that they were doing for some time. And what that said to me was that there's a great opportunity there to invest in some retraining and to make sure that we have the best practices in Maryland for how we are handling those cases. And I'll just say that in my professional life, I'm an attorney, and I had the opportunity to be in court where one of our agents that performs this work had to submit a report for an allegation of abuse. And I will say that the report that I saw, it did not strike a great confidence. In interviewing the parties that were the party to the case, I was able to get a lot of information that was not in the report. So I am hoping that with the opportunity to have a decline in caseload, it looks like a much needed opportunity to spend some time investing in the staff that we have in training. So my question is, are we taking that opportunity to make sure that we use the additional time we have to invest in our staff?
Absolutely. Thank you, Delegate Henson. And we had similar discussion last year when we had our budget hearing, and I remember saying that training is key and very important for our organization at all levels. But training, making sure that particularly the case notes are there. You mentioned that there was information missing that you were able to gather at a later time, but it was not available to you. Well, one of the features that we have enhanced that go parallel with the training that you're referring to is the ability for the caseworkers in CDMs now to enter the case notes. In the old system, that was something that the caseworkers were always complaining. But they would go to visit and remove the child, take the action. And then by the time they came back to the office to enter the case notes, as you and I know, if there's a gap, some information would be forgotten and not entered. But now with CDMs, it's mobile. So the caseworkers are able to enter case notes while they are completing the investigation. But as far as continuing education and training, is a commitment that we have to our staff at all levels, at all times. On the declining caseloads and the ability to also enhance our staffing and make sure that we have the skill set that we need. Excellent opportunity. And I keep saying that after the pandemic, how we're going to look like could be totally different than how we looked like pre-pandemic. And we need to take the opportunity and use all the lessons learned to put into place and enhance the services that we provide.
Thank you, Madam Secretary. Thank you, Mr. Chair.
Thank you. Let's go to Delegate Young.
Thank you, Mr. Chairman. Madam Secretary, good to see you. You as well, Deputy Secretary James. I know that the analyst touched on this and you touched on it a little bit related to Family First. I apologize in advance the open-endedness of this question, but I hope, could you share for the committee while we have you here, some of the challenges you've seen? The program is generally new. It's still being rolled out. I know we've had conversations about how you all have been ahead of the game compared to other states, but can you share for us some challenges you've had related to the implementation of Family First over the last year?
Thank you, Delegate Young. And therefore, the ongoing interest on Family First, because I think it is Family First, the key opportunities that the department is going to have to truly revamp and change the child welfare system in the state of Maryland, which is something that we really want to do. And it's one of the reasons why we decided to submit our plan and obtain approval to the plan, right? Some of the challenges, I'm going to speak at a very high level, and then I want my executive director for child welfare to elaborate on my responses. But when we made the decision, we went in knowing that Family First was not only new to the state of Maryland, but interesting enough, it was also new to the Children's Bureau, to the federal government. So they embraced the act as when it was signed, but they knew there was a lot of work that they needed to do on their end to provide the guidance and the steps that the states needed to be able to successfully implement the plan. And I'm going to stop here, and if I may, I'm going to ask my Executive Director for Social Service Administration to elaborate on what I just said. Michelle Hart.
Yes, thank you so much, Secretary. I just want to echo what the Secretary has shared, and thank you so much, Delegate Young, for that question, because we also have kind of questioned, if you will, if we are moving about this in the right way. And to be perfectly honest with you, we believe we are. But there has been some challenges as it relates to getting the guidance that we need from our federal partners. Now, that doesn't mean that they're not engaged with us, but this has been an evolving initiative, right? And so they're learning, as the Secretary said, as we are. And so it's really being able to move ahead or move forward as we are waiting for particular guidance to come through. But I did have conversations most recently with some of our our national experts, as well as the other jurisdictions, kind of getting a pulse for where we sit with some of the things that we're doing. And believe it or not, we seem to be either ahead, as I believe you said, Delegate Young, or on par with the other states in terms of our implementation. What I learned is that there are a total of 10 states that have submitted and 2 tribes, and there are only 9 states that have been approved. When we look at some of the submission of our work, we also find that we're ahead of others in terms of our submission. But the key is to be able to get more guidance, if you will, and continue to keep our hands on the pulse as it relates to getting this information from our federal partners. And again, they're learning along the way as well. But we have been proactive. And I mean, when you talk about systems transformation, I think one of the key things that we've learned in this time frame is the importance of buy-in and making sure that we're engaging all of our providers and our partners and staying in tune with other jurisdictions as it relates to how do we move this work forward. I will be honest with you, I think we're in a very good place. I've heard that some other states have kind of stymied with respects to this work, still trying to get fuller understanding and guidance from our federal partners. We have a very close relationship with them, and they're encouraging us to continue moving forward in the direction that we have been moving. So we're just hopeful that we will get our plan approved by April, and that will obviously allow us more flexibility, if you will, and enabling us to claim our federal funds.
Thank you, Ms. Fleur and Secretary Badea, for the details. Everything you said, it makes complete sense, and I want to give you context to the question. You already know this, that you can't implement Family First without the help of your local providers. Ms. Farr, you totally brought that up in your comments. We have these providers in all of our districts, and I just want to bring up to you all I feel that there's, just as you said, there's confusion, not confusion, there's a frustration related to, it's a new program, dealing with the feds. I feel like it's at a local level, that's that same frustration with folks that are trying to also get guidance from you all. And I would be happy to help facilitate a communication between folks. There just seems to be a break in communication from some of the folks on the ground that are also completely willing and ready to go, but waiting. And what you said makes complete sense. You were waiting as well. But if there can be maybe a bit more robust communication with those folks who are going to be implementing on the ground, I'd love to see it and help to facilitate. Thank you, Mr. Chairman. Thank you, Madam Chair.
Absolutely.
Thank you. All right. Let's go to Senator Eckert.
Thank you very much. And part of my question was answered. And the Secretary and her team know that we've had many conversations about Family First, because I had been on a work group with NCSL regarding the implementation. And I was very impressed that Maryland was way ahead of the game, but we hadn't really communicated that very well. And I just wanted to reiterate, I think all the providers are anxious and waiting to be engaged. So had COVID slowed this down at all, the ability to engage providers, or is it just strictly waiting on, feedback from the federal level?
Senator Eckhart, thank you so much for that question. I would say it's a combination of both. There was an opportunity for us to have to shift our attention because of COVID-19 and making sure that we were communicating the needs with our locals in terms of responding to the community and what did that look like and developing guidance around that. And so there was a slight shift, if you will, in our attention. I think we've picked up the momentum. And we've been all along, though, I would say since the middle of 2020, we've had our Family First Prevention Implementation Team. And I know that there is a cadre of individuals that are in attendance there. I know that we have engaged with some of our providers most recently in the past couple of months, and we've shared that we are going to be, of course, bringing them to the table to help us to develop our programming even further.
Could I follow up with another question, if anybody doesn't mind? Now, I'm shifting gears a little bit. I understand there have been some procurement guidance or changes within the department. I've been hearing this out of DBM and other places. Are there changes, and does that impact your ability to address procurement?
Thank you, Senator. I'm going to have my Deputy Secretary for programs for operations that within the has the procurement of the agency to answer that question.
Great.
Deputy Secretary James, if you would.
Thank you.
Yes, thank you. And thank you for this question, Senator Eckert. There certainly was the shift with the creation of the Office of State Procurement within General Services. The procurement team within DHS is still, it's still at DHS. So our operations in that area, we have not seen a disruption. And I will also say we have historically had with when we went through DBM, and now that it's with Office of State Procurement, we have a very good relationship with them and a very close working collaboration with them. Certainly during the COVID pandemic, we've experienced some challenges in procurement, really having to change our work processes. To be very honest, our procurement is largely paper-based historically, and changing to a telework environment has been challenging in that area, as well as having to make some of the adjustments to reflect that. So we have been working through those issues. I think we're have most of them behind us. As you may know, sometimes when you make a mistake, it'll take you 3 times longer to clean it up than it was to do the job the first time. And that's been some of what we've experienced. But no, I don't think we've had issues in that area or changes. And certainly we continue to look at our procurement operations. The support we've gotten from Office of State Procurement is excellent in terms of helping us train not just our procurement officers, but also those within the program areas who work with these contracts, and trying to give them the technical expertise in order to structure a good contract and have a package for procurement that is very tight and strong, which helps us get through the RFP process faster.
Thank you. And that ultimately then impacts your work with your partners in the community, correct?
Absolutely. Absolutely.
I was just wondering, because I had heard from folks over in General Services that it had changed rather than from the departments. And that's why I was asking it, because when procurement comes up and you've been needing to be so engaged with providers. I just was curious how that impacted that relationship, or if it slowed it down, or what other checks and balances there were in place. So thank you.
Thank you.
Thank you. And now Senator Young.
I'm good. Delegate Young and Senator Eckert covered what I was going to ask.
Wonderful. Thank you. And Chair Griffith.
Thank you, Mr. Chairman. And I know we have several witnesses that are going to testify. So I'll just say, Madam Secretary, to you and your panel, thank you for your very direct responses to the analyst questions. I do want to reinforce the comments that started back with Vice Chair Valentino Smith and carried throughout the conversation. I think if there's a common thread, it is that we certainly don't want to leave federal money on the table and use state money if we can avoid it. So anything that we can do to help facilitate advancing those processes so that we can take advantage of the federal resources that can pay for some of these things that we're using general funds for, we would really love to see that. I share with others a desire to see us advance the family first. I know you're working with your plans. So please let us know offline, Madam Secretary, if there's something that we can do to help with the actuary or whatever process you need to get through that so that we can expedite that process. Thank you so much. Thank you, Mr. Chair.
Thank you. And with that, I want to thank the department for testifying and answering questions. We're going to move now to the witnesses. We have, I believe, 5 witnesses signed up. So we will take them in this order, and then we will hold questions for the panel until afterwards, if that's all right. We will start with Margot Quinlan, Kevin Keegan, Rachel Faulkner, Ann Geddes, and then Francis Smart. So we can start with Ms. Quinlan. Please go ahead if you are in here. Yes, there you are.
Yeah, I'm here. Thank you. Well, thank you, chairs and members of the committees. My name is Margot Quinlan. I'm the Director of Youth and Older Adult Policy at the Mental Health Association of Maryland. We are testifying today to raise some concerns with the current system for voluntary placement agreements, or VPAs. Mental Health Association would ask that DHS provide a report on best practices and possible alternatives to our current VPA model. And some of the folks after me are also going to speak on this in more depth, but the original intent of these policies were really to provide parents and guardians options for their children to enter long-term treatment when in-home or community-based treatment interventions just were not suitable, and when the family needed financial support in accessing the appropriate level of care. And while originally created with good intent, children are really now experiencing significant hospital overstays, long wait times to receive treatment. The process is really overly burdensome on families, is not easily navigable, and is really dependent upon a treatment system that simply is not robust enough to support children and families who are seeking high intensity behavioral health treatment, often in a moment of deep crisis for all involved. Ultimately, many parents and guardians are still being forced to relinquish custody of their children just to access critical behavioral health services. We believe that families should face as few barriers as possible when accessing life-saving mental and behavioral health services for their children. We believe it is time to begin a conversation about how our system of care might be more child and family-centered. And we also really believe that parents should not have to involve DSS to access behavioral health, and would ask these committees to really help bring the stakeholders to the table to think through these proposals, so we may better understand the scale of the challenges currently being faced and work collaboratively on identifying solutions. Our testimony, which is submitted, goes into this in a lot more depth, including the history of this program, and we're happy to answer questions now or in the future, and really thank you all for your time and attention to this issue.
Wonderful, thank you. We'll now next move to Kevin Keegan. Mr. Keegan, please go ahead.
Thank you. Chairperson Griffith, Chairman Resnick, Vice Chair Valentino Smith. My name is Kevin Keegan, and the first thing I want to do is agree with everything that Ms. Quinlan just said. But I am the Family Services Division Director for Catholic Charities of Baltimore, but I'm also a member of MARFI, which is a membership organization for providers in Maryland. I'm here today as one of the aforementioned anxious and frustrated providers to support the department and ask that the committee do the same as we continue to rethink how to address the needs of our highest intensity youth. I really want to, I guess, first mention how much we appreciate the partnership with the department through COVID. I can second everything the secretary said in terms of the flexibility with licensing and all that they've done to really work with providers through this. And especially, I want to thank the department for providing supplemental payments to support some of the additional costs we've experienced through the year. But back to the issue of high intensity needs, I just want to point out that, you know, it plays out in a few ways. Again, Ms. Quinlan just mentioned a few of them, or a couple of them, for many years. And honestly, well before this administration began, the state's been struggling with these exact issues. First, we place too many children out of state due to the lack of flexible funding models in Maryland to support keeping children here. We've shown how providers can step up to partner with the state through certain crises when out-of-state programs shut down or when we had to pull kids out of programs. I've always commended the efforts of, especially of Deputy Secretary Greg James and others, you know, during those times, and we were able to really think creatively about individual kids' needs and how we can place them with providers with a more flexible funding model. So we, you know, I share the Secretary's disappointment about possibly another 4 or 5 years before we get to a new funding methodology. This has been going on for a long time, so we really look forward to a more flexible funding methodology. A second way it plays out is with the overstays in hospitals, and this too isn't new. I mean, if you go back 25, 30 years, the Lisa L. settlement focused on the exact same issue of kids being stuck in the hospitals. Sadly, I wish I weren't old enough to remember Lisa L. because it was 30 years ago, but I am. This problem is made much worse due to the loss of 3 RTCs over the past few years, and there remains a lack of availability of RTC beds. COVID has also made it more difficult to get kids into RTCs because some of the RICAs are even have decreased their capacity through COVID. So it's, the third way it plays out is with parents who are unable to care for their child and they come to the state for assistance. And the only way to accomplish this at times is for them to use the VPA process, requiring them to give up custody and pay child support to the state to gain access to the resources they need. Each of these problems is the direct result of the state lacking a true system of care to support youth and families, including community-based, evidence-based, in-home supports that includes a robust crisis response model to support families during those most intense moments. And let me just say, the hospital is seldom where they really need to go. The hospital is only the place of last choice. There's nowhere else to go. You can call the police or go to the hospital, neither one of which are what the child or family typically need at that moment, but it's all that's available. The Family First legislation is intended to help with this exactly. And if the state can truly work collaboratively and coordinate Family First interventions with existing Medicaid funded services with some smart general fund investments, all of these big problems will ease over time. Providers such as us stand ready to partner with the state. We aren't feeling the progress over the past year. I'm hoping maybe that's just some communication gaps, because as a group of providers, we haven't felt quite so included over the past year as we had prior to that. But I know it's been an incredibly crazy year, so that's not accusatory in any way. But Catholic Charities of Baltimore and Marfie asked the committee to fully support the work of the department by engaging the agency and stakeholders to reimagine how we can provide care for our children, including rethinking how to place the youth in high intensity placements before getting to the child welfare system. Thank you for your consideration.
Thank you. Let's move to Rachel Faulkner.
Hi, good afternoon. Rachel Faulkner here with the Maryland chapter of the National Association of Social Workers. You have our written testimony. I had planned to use all of my time to really talk about the VPA process. I think the last 2 presenters really did a great job. I just want to highlight a couple of things. When we talk about children in need of services, and Mr. Keegan mentioned it, having a system of care, and that means at any point in the system, depending on what the needs are and what the medical necessity is, that you can get a bed, or you can get outpatient treatment, or you can get an assessment, whatever the need is, that there is a service available when you need it, so that you're not in those high intensity moments looking to an emergency stay at a hospital. I would also say that this is not This is not something that is the sole responsibility of the Department of Human Services. This is something that we're very interested in an interim look and review that would include the Department of Health, including the Behavioral Health Administration, and the Department of Education, because oftentimes when these placements occur, there's an education component with special education services being provided. And so it really has to be an interagency review and process and support for families that are looking to serve their kids. The second point that I want to make that is not in our testimony, but I'd be remiss if I didn't mention it. The budget analysis spends a great deal of time talking about caseload ratios and whether the state is meeting them. One of the things that has happened since Maryland passed its Maryland Child Welfare Accountability Act in 2016 is that the Child Welfare League of America's standards have moved from a caseload to a workload methodology. So I just want to say that I think that Maryland is probably out of step in how we look at caseload because the national standard has changed and we probably just haven't adjusted to meet that new standard. And so it's something that I think we should look at, particularly as there are recommendations for the department going forward through the interim to do certain things looking at that caseload that maybe we want to look at it again and think about how we look at a workload study instead. And with that, thank you for your time.
Thank you. And we'll move to Ann Geddes.
Good afternoon. Thank you, subcommittee members. My name is Ann Geddes. I'm with the Maryland Coalition of Families. Among other things, MCF provides one-to-one peer support and navigation services to parents and caregivers of a child with mental health problems. And I also would like to bring up the issue of trying to sort out the voluntary placement agreement process, which is pretty broken right now. So this is 18 years after they were originally established. Securing a voluntary placement agreement is a cumbersome process, slow to be approved, and increasingly rare. Problems with accessing VPAs are resulting in long hospital overstays while families try to wait to get an approval. Some families are now again resorting to custody relinquishment, which VPAs were intended to prevent. There are numerous problems with the current system, and I have just one example from the families we work with that I wanted to give. We know a mother who tried to secure a VPA for residential treatment for her son who was diagnosed with bipolar disorder and had a history of threatening and harming other family members. He had once already been charged with assault on a family member. She was denied the VPA and told that she had not exhausted all types of community-based services. She was told she needed to continue to call mobile crisis when in need, to look into accessing more outpatient services, and to look into respite services, which were not available because of the pandemic. Arguably, her son was far beyond needing more outpatient services when she finally approached DSS seeking a VPA. Subsequently, the young man attacked his mother with a knife and is now sitting in Cheltenham, a DJS facility, awaiting placement in an RTC. If the VPA had been approved when the request first had been made, this all potentially could have been avoided. When VPAs were first developed, there was the intention that they could be used by families who lacked Medicaid, primarily those with private insurance, in order to access the array of Medicaid benefits without relinquishing custody of their child to the state. Now VPAs are primarily used to pay for the educational component of a residential treatment center stay, for youth, both those with Medicaid and with private insurance, who do not have a non-public school placement on an individualized education plan or IEP. Families are being required to pay child support to DSS to cover the educational costs of their child. This is probably a violation of the Individual with Disabilities Education Act. For multiple reasons, the VPA process must be re-examined and improved with DHA and MSDE. So we urge the committees to work with the department and stakeholders to come up with solutions. Thank you.
Thank you. And then we had one more person signed up, Frances Smart, who is signed up as an individual foster parent. I'm not seeing her in the chat. So not seeing her, we will, I believe she has written testimony submitted. So I will ask if there are any questions of this panel. Nope. All right, seeing none, I want to thank everybody for coming. And again, apologies for my tardiness. And we will see you all again next week for continued budget hearings. Just a reminder to the House Subcommittee, we are voting now. There should be a link in your inbox. So please join us immediately for a vote on one bill. Other than that,